and I'd be pleased to answer questions.
Absolutely. Paul would appreciate all your challenging questions, and we have a few minutes to do that before we have a bit of a table exercise. So let's open it up. The only thing I would ask, Melanie has a microphone. Please, so that everybody can hear what your question is, would you let her come and give you the microphone? Thank you. Questions?
Question is, I guess, how do you see long-term care facilities fitting into primary care, Paul?
Into primary care?
Well, into the whole picture.
So a couple of pieces. We lost 78 beds in the southeast region due to financial viability of a particular home. So that home closed down. We've said to the ministry, that's our money. You can't, I appreciate that they take back the licenses, but they can't take that away from us. We want every cent that was allocated to that home to be kept for us until we determine how best to allocate that. So we could allocate that by creating a new home of 78 beds. Probably don't want to do that because the financial viability will still be at risk. We're a LHIN that has more bed homes that are under 100 beds than probably most LHINs, maybe not compared to the north, but the financial viability of those LHINs those homes are very important. And we can't, because of legislation, we can't invest in those homes extra money. So if someone has mold on the floor or something, we can't put money into that because it creates an unfair advantage to all the other homes. So we are looking how best to use that 78, and we're developing a long-term care strategy right now. It's in early days. We know the ministry is considering redevelopment, and if they do come out for redevelopment, we want to be ready to pounce on that with our 78 beds and other beds that might be made available. But we don't know if that's going to actually happen. We know they're considering it. But in HealthLinks, long-term care is involved. In addition, we created recently a behavioral support units and behavioral support services, and that's to help long-term care homes that often have a patient that will have a behavioral issue and that they have to move them to the emergency department, and then they feel at risk in bringing the patient back, so the patient is often admitted, becomes an ALC patient, etc. The behavioral support services and unit go out, participate, work with the home, and help prevent that from becoming a visit to the emergency department. So we're more in flux with long-term care. We are working with long-term care, and long-term care will be added to that list shortly.
Paul, you appear to define system as LHIN-wide, and I understand that and get it. If other CEOs from other LHINs were giving a similar presentation, would they be charging down the same paths?
There would be some similarities. They all would have HealthLinks. We probably are more energetic around primary care than other LHINs. They all have issues related to addictions and mental health, and that will be a provincial agenda. Many of them have the hospital issues, but you know, it's a very different environment. You can't compare our environment to Toronto, and you can't compare our environment to the Northwest. I had someone from the Northwest said, Paul, you don't know anything about access. Our closest hospitals are 400 kilometers apart from each other. It's a real different environment. But many of the issues that they're facing are similar, and we talk, the CEOs meet regularly, really regularly, and we learn a lot from each other. So I think they've learned a lot from us about primary care and addictions and mental health. We've learned a lot about assisted living from them, and also about long-term care and the hospital stuff. We're all trying to sort that out, and it's very different in each of the LHINs.
Paul, Richard Schooley, Perth Smith Falls. I've been coming to gatherings similar to this for several years. I think certainly in the Perth Smith Falls area, there's a general understanding and a general enthusiasm, a general feeling of urgency to be responding to integration and collaboration. The challenge that we've got is that I think we accept that every of our districts, 7 hospitals, 7 districts, 7 health links, they're all going to have some different nuance to them. In our case, we're anxious to get at something, but we need a framework, we need a vehicle, and we need some help in pulling the resources together to have it happen. I guess we like to think, and I'm speeching rather than questioning, and I apologize for that, but we've been, as you know, very involved in building linkages and synergies for a long time. I mean, Perth Falls Hospital has been Lanark County Mental Health. Perth Falls Hospital has been Lanark Community Support Services. Perth Falls Hospital has been sexual assault and domestic violence program coordinators. I guess I'm missing probably some others that initiatives that are there. We have a LEAD program that connects to our mental health and our police and our ambulance service and social services. All those things, we understand those. We think there's the opportunity to do more in that vein, but we need a vehicle in order to get there.
So I'll tell you an example of what you've done, an example about what you're about to do, and an example of what you can do in the future. So Health Links, you're stellar. It's a great story coming out of Rideau Tay. Great story, different approach than some of the other Health Links, but a lot of similarities and commonalities, and there's a great involvement from a number of providers. So that's a really good story that you're involved in, and that many health providers are involved in, that does have success, will have more success, and is really addressing coordinated care plans for complex patients. So that's a good story. The addictions and mental health, what we're looking at, we want to find as much as service efficiencies for the patient and quality, we will find administrative efficiencies too. Those administrative efficiencies, we don't want any of that money back. That money goes back into service. So if anything out of addictions and mental health, we'll see more investment or reallocation of investment into frontline care. So services won't decrease. If anything, they'll increase. But it will allow you, your hospital, much more common, more consistent access to addictions and mental health services. Great, you have that relationship in a couple of areas, but overall the entire addictions and mental health service, and you will have a consistent access to those services like the hospital in Belleville and the hospitals in Kingston. With sustainability, that's what you really need to be engaged in for the future. We need to see what is the role of Perth Smith Falls? What is the role of Kingston General? What's the role of Quinte Healthcare in a regional system of integrated hospital care? And that will be partly you understanding, the services that you currently provide, the viability of those services, what might be trade-offs, what would be services that should grow in Perth Smith Falls, and what services maybe you should trade off. If you're really trying to make sure that you're providing the right access. And of course, transportation comes into play in all of this, but we want 7 strong hospitals providing excellent care in a regional system. So what's your role? In fact, we're going to stop calling it sustainability. We're calling it sustainability a role project. What's the role of Perth Smith Falls? What's the role of KGH? You need to really, you need to bring your forces to bear in helping us define what those roles are. So the 7 hospitals working together saying, what is the role of each of us in creating a regional system of care?
Hi, Paul.
Hi.
Alfred O'Rourke from Sherwood Park Manor and Mapleview Lodge. You talked a little bit about long-term care, and there is a lot of need, and I think there's good leadership in long-term care as well, and I believe that what we need to do is sit down and start talking about the things that we need to do to correct that system and move it forward. I think there's willing. I think we've started some dialogues with you with.
Yes.
I think in the greater Southeast, I think there's opportunity to start looking at those types of opportunities, because we're in a lot of boxes in long-term care, and we get the people at the end of their life when all the other pieces of the addictions and mental health and the hospitals, and we get all those people at the end of their life, and we have to cope with all those end of life things, not just in one. So the system is changing significantly shortly. So my question is there an opportunity to sit down sooner rather than later with and offer long-term care administrators and key directors of care opportunity to sit down and talk about these things strategically so we can start making some changes that we need to make in the system, get it through you guys to the Ministry of Health, because the time is now to do that before we're swamped beyond, for frontline staff to be swamped beyond belief.
We will be coming to long-term care shortly. We're doing some data analysis right now, and we want to bring that to the long-term care administrators and say, help us understand this data, and then help us understand where there's some more analytics that need to be undertaken. So you'll give us some advice after we give you some of the preliminary data, and you'll tell us what other things we need to look at that we don't understand. We'll do that, and then we'll start discussing exactly how do we develop a long-term care strategy.
So Paul, I think it was on the slide dealing with the health link, and you talked about the notion of the patient being in the center, and it seems to me you also, yep, you just went by it, I think.
Wasn't that one?
No, it was the one with the,
This one? Oh,
no,
that-
back. Strategic directions. Oh, you just went by it.
This is addiction
Yeah.
to mental health.
Okay, sorry. But the notion was that the patient was in the center in the wheel with all the services. And I know that you are doing some things to correct the patient's perception of how he or she is managed through that system of care. I know you have the regional community patient advisory councils, you have the visioning day, and so on and so forth. But my question is, so when or how are we going to communicate what it is you're doing to improve that perception, okay, to the patient?
So we had a visioning day for addiction to mental health, and we asked them to tell us in those sessions. We had vignettes, we had patients actually our clients actually at the meeting telling us what wasn't working. And they were very articulate. We've been constantly providing the information on the website and getting information out to people. Addiction to mental health is an interesting concept because there's been a lot done on addiction to mental health that never went anywhere, and there's complacency in the industry because of that. And in fact, 10 years ago, there were these regional mental health implementation task forces. I think $1 million was spent on each of the 7. And when we were pulling together that task force, I was working in the Southwest at that time. I had patients saying to me, okay, Paul, I'll come to the table this last time, but I tell you, if you don't implement, I guarantee you'll never get me to the table again. So when we held the visioning day, we took the bold approach of saying that we guaranteed that when the task force concluded and identified recommendations that we would implement, that this would not sit on the table. So we believe this has been totally built. Also data, we understood the data, but we really listened to the patient. We understood what wasn't working. We confirmed that understanding in other jurisdictions, et cetera, and we've been getting that message out, perhaps not as well as we should, but we don't have anything implemented. I really feel a tremendous amount of responsibility to be able to sit in a room with clients and say, this is what we've done when we've done it. I don't want to sit there and say, well, we're at this stage now, and we think this is what's going to happen. I want to be able to say, this is what has happened. And so maybe we should be communicating better with clients right now. I want them to show that we kept our promise.
So that then would apply to health links as well.
With the health links, these patients are directly involved. So we're focusing on this 5% that represents 60% of the cost. And it's not their fault that the costs are so high, and it's not the organization's fault that the costs are so high. It's the system letting these patients down. So when they identify a complex patient, that patient is involved in the development of the complex or the coordinated care plan. And one of the health links, I attended a session, and I think most have had similar type sessions like this, but there was one session where I attended where they brought providers from the health link into this meeting room, and each table had a patient with his or her family members with them. And one was a baby with multiple complex issues. So this wasn't your typical, but there were others who were elderly and frail, et cetera. And they talked about what was working with Health Links and what wasn't working too. But the one thing that was common was that they were involved in their care, in developing their care plan. So they were actually contributing to that, and the providers were listening.